Before we start, what is tracheostomy? Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. So, how does this differ from your tracheotomy? Basically, tracheotomy implies the formation of an opening that will close spontaneously once the tracheotomy tube has been decannulated. On the other hand, tracheostomy implies formation of permanent opening that remains open after the removal of the tube. Tracheostomy continues to be a useful tool in the management of acute airway obstruction, for the administration of general anesthesia in selected head and neck oncologic and oromaxillofacial surgeries, pulmonary hygiene, for elimination of dead space, treatment of obstructive sleep apnea, and lastly in prolonged mechanical ventilation, especially in those with respiratory disease, neuromuscular diseases, and depressed mental status wherein the patient is unable to protect the airway. The important surface landmarks in tracheostomy include your laryngeal prominence, your jugular notch, your cricothyroid membrane, and your cricoid cartilage. To avoid complications during tracheostomy, the following anatomical relationships are important. Your inferior thyroid veins that arise from a venous plexus on the thyroid gland and descend anterior to your trachea, your left brachiocephalic vein, jugular venous arc, and pleurae may be encountered particularly in infants and children. Your small thyroid imma artery is present in approximately 10% of people. The thymus that covers the inferior part of the trachea in infants and children. And lastly, the trachea is small, mobile, and soft in infants, making it easy to cut the posterior wall. The following are the minimum instruments needed in tracheostomy: local anesthetic, which is usually 1% lidocaine, scalpel, forceps, suction, tracheostomy tube, suture set, and retractors. Unless the patient can safely be intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. If there is concern about the anesthetist's ability to maintain an airway, then the surgeon should be present during induction. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction. And a set of tracheostomy instruments should be set out before induction of anesthesia so that an emergency tracheostomy can be done if required. Place the patient in a supine position with neck extended by a pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Sterilize the skin of the anterior neck and chest and drape the neck. If the tracheostomy is being done under local anesthesia, the face be uncovered. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis as a result of scarring. Run your finger up the midline of the neck, starting inferiorly at the sternal notch. The first prominence encountered is the thyroid isthmus, followed by the cricoid. Alternatively, identify the thyroid prominence or Adam's apple. Moving inferiorly, the finger slips into the depression of the cricothyroid membrane, followed by the solid prominence of the cricoid cartilage. Make a horizontal incision 1 finger breadth below the cricoid prominence. It is cosmetically preferable to a vertical midline incision. Extend the incision through skin and subcutaneous tissue. Platysma is generally absent in the midline. Take care not to transect the anterior jugular veins, which are just superficial to the strap muscles within the investing cervical fascia. They can be preserved and retracted laterally. Dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. Identify the midline cervical fascial plane between the sternohyoid muscles. Divide this intermuscular plane by spreading with a pair of scissors. Repeat this maneuver to separate the sternothyroid muscles and retract the muscles laterally. The trachea and cricoid can now be palpated. The thyroid isthmus overlies the second or third tracheal rings. Retract the isthmus superiorly with Langenbach retractors to expose the trachea. Only very rarely does the thyroid isthmus need to be doubly clamped, divided and ligated, or if small divided with electrocautery. Expose the infrathyroid trachea by carefully porting the overlying soft tissues with a pair of scissors, taking care not to tear the inferior thyroid veins. Ensure that the surgical field is completely dry before proceeding, as it is difficult to achieve hemostasis once the tracheostomy tube has been inserted. A silk traction suture is passed through the anterior tracheal flap and loosely secured to the skin. Insert the introducer into the tracheostomy tube. Ensure that the tube has been inserted into the tracheal lumen and not into a false passage in the paratracheal soft tissues. Complications of tracheostomy can be classified as intraprocedural, early defined as less than 7 days, and late more than 7 days. Intraprocedural complications include airway fire, since drapes, ETT, and alcohol-based antiseptics are potential fuel sources. Bleeding, which is usually secondary to anterior jugular vein injury or from the bleeding edge of thyroid, and lastly, pneumothorax or pneumomediastinum, which may potentially be due to direct injury to the pleura, dissection of air along the trachea, or rupture of an alveolar bleb. Early complications include infection, tube obstruction since tracheostomy bypasses the natural warming and humidification provided by the nasal passages, pressure ulcers resulting from pressure of tracheostomy faceplate, and lastly, accidental decannulation, which has been associated with patients with altered mental status, increased secretions, and nursing shift changes. Late complications include tracheal stenosis because of scarring and local injury, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula.